Good afternoon, everybody. Today, we'll have a global fronted dialogue on antibody-drug ADC in urothelial carcinoma. Today, we have invited a lot of famous doctors from globally. So first, I'd like to invite Professor Powles and me to chair this meeting. Professor Powles. Yeah.
Jun, I just wanted to start by congratulating you on what a fabulous presentation you made yesterday. I thought it was a landmark moment for patients with urothelial cancer. I think it was a great moment for Chinese research, and I think it's a testament to your hard work and your incredible work with the team. So congratulations to you and to everyone else in your research group that were able to take this over the line. It's great for Chinese patients. It's also great for global patients. So congratulations.
Thank you, Powles. And now, this is the agenda this afternoon. Firstly, we will have Professor Xinan Sheng a review of the RC48, C016, and C017 studies. Then we will have panel discussion. I'm very glad to introduce Professor Xinan Sheng. Maybe many people know him. He comes from Peking University Cancer Hospital. And Powles is very famous, global famous doctors. Everybody know him, yeah?
Well, that's kind of you.
Professor Gupta. Gupta is from Cleveland, and the very famous tumor center in the world. And Tian Zhang, where the could you introduce the Southern?
Geomedical oncologist at UT Southwestern Cancer Center in Dallas, Texas.
Very long name, so I could not. So, please, Professor Petros Grivas, could you introduce yourself?
Thanks, Dr. Go. I echo Professor Powles. Congratulations for a fantastic presentation yesterday, landmark moment for Chinese and global patients. I'm Petros Grivas. I'm a medical oncologist in Seattle, United States.
Okay.
I'm a professor at the University of Washington and Fred Hutchinson Cancer Center. Thanks for inviting me.
Thank you. Thank you.
I also want to congratulate you. It was just a fantastic moment. The presidential session was very memorable for years to come.
Okay, thank you. Thank you all. Thank you all. So now, firstly, I do want to invite Professor Xinan Sheng has his lecture about the review of the C016 and the C017. Please, Dr. Sheng.
Okay. Thank Professor Guo for kind introduction. So firstly, today I will review the two studies. So as we know, HER2 is a potential biomarker. In the past 30 years, anti-HER2 treatment cannot achieve the success. In our study, HER2 expression in about 69% of patients has HER2 expression. This year, a study from U.S. population, there's about 50 to 60% patients had HER2 expression. So 10 years ago, we conduct 7 studies to evaluate the DV in the metastatic urothelial carcinoma. The RC48 C005 and 009 trial had demonstrated the DV monotherapy best efficacy and accept safety in the second line treatment. Today we will show the 2 studies, RC48 C014. This is a phase 2 study to assess the DV in combination with toripalimab for the unselected HER2 population. In this trial, the objective response rate was 76% for all patients. For the HER2 expression patients, IHC 1+, 2+, 3+, the objective response rate 76.3%. The median PFS was 9 months, and overall survival reached 33 months. So based on this fund, 4 years ago, we conducted the phase 3 trial, RC48 C016 study. Yesterday, Professor Zhang presented the data. This is a randomized phase 3 study. We enrolled metastatic urothelial carcinoma with no pre-system treatment, and central label confirmed HER2 HSC 1+, 2+, or 3+. About 1,800 patients was screened, and 484 patients enrolled this trial and randomized to receive the DV combination with toripalimab or chemotherapy. The primary endpoint was PFS assessed by blind independent response center, and overall survival. The second endpoint was PFS assessed by investigators, objective response rate and safety. Yeah, this is the patient flow. We can see the 2 arms were balanced. So the first, the primary endpoint, progression-free survival, according to BIRC, we can see that the DVT arms, the median PFS reached 30.1 months, and Kim arms reached 6.5 months. We have a significant improved the PFS. The PFS subgroup analysis shows all prospective subgroup benefit from the combination treatment. So overall survival analysis shows median overall survival in combination arms is 31.5 months, and Kim arms is 16.9 months. The OS subgroup analysis was consistent across all prospective subgroup. So in the combination arms, the objective response rate is 76.1%, and the Kim arms is 50.2%. And yesterday, the discount showed that the CR rate is low in our trial, just only 4.5%. We found the CheckMate 901 trial and EV302 trials. The most complete rate response contributed by the patients who just have the lymph node metastasis. In our study, the patient only lymph node metastasis, just the population is low. So our study CR rate is low, but not the, I think maybe if we have more patients had lymph node metastasis, I think maybe more than 5%. Yeah, the direction response showed that there was a significant improved in DOI in patients with DVT arms. So we see the subsequent system treatment. Most patients in Kim arms had subsequent treatment, and 40.2% choose anti-HER2 ADC treatment. So this is the safety summary. Incidence of grade more 3 treatment-related adverse events is 55.1% in combination arms versus 86.9% with Kim arms. So conclusion for this study, this is the first phase 3 trial demonstrated for the first time the superiority over an anti-HER2 antibody ADC and plus the PD-1 antibody in a biomarker selected patients population with MUC. So next study is RC48070 trial. This trial assessed the DV in combination with Tolimod for the MRBC patients. This is a study design. This AskGeo meeting, I presented this data. About 47 MRBC patients enrolled this trial and received 6 cycle treatment and then give the radical surgery. This is primary endpoint results. In our study, about 63.6% patients achieved pathology complete response. The PCR rate for the T2N0 patients appeared higher than those for the other subgroups. The PCR rates were generally consistent between patients with poor uterus cancer and patients with UC others different. The subgroup analysis demonstrated the PCR rate for the HER2 IHC 3+ subgroup was nominally higher than those for IHC 1+ and 2+ subgroup, regardless of PD-L1 expression. In our study, the 1-year event-free survival rate was 19.5%. And 18 months event-free survival rate was 85.9%. The median overall survival not reached. So most common treatment-related adverse events, most incidents just grade 1 or grade 2. This ESMO meeting, EV 303 trials showed the EV combination with pembro for the MRBC, but just patients for the cannot receive the cisplatin treatment for neoadjuvant. Our study is the first prospective study showing the ADC in combination with PD-1 antibody as preoperative treatment provided prominent outcomes in operable MRBC. So that's all. Thank you.
Okay. Many thanks.
Thank you. Hi, Tom.
So can I go, Joe? Joe, you go. You go, Jun.
I'd like to invite you to host the panel discussion.
Great.
Do you have time?
Yes, please, of course.
Yeah.
I'd like to start by asking each of the panelists, and Shilpa, I'd like to start with you, if I may. What is your overall opinion of these 3 trials with disitamab vedotin and toripalimab?
I think, this is really great data, and thank you for leading the way in this. You worked so hard over the last 10 years and revived the HER2 work in bladder cancer, which I know Tom worked on many, many years ago also with older drugs. I think the data that we saw yesterday is just opening another option for patients who, as we know, EV pembro is great, but it is not available in outside of the US, Europe, and many other select Asian countries. So I think it's great to have more options with novel combinations. And this combination offers that. It's because this study was only in the Chinese patients. I think we just want to know what is the prevalence of HER2 in the rest of the world. It appears it's lower in the US patients. And also it appears that in the Chinese population, neuropathy was not as bad or frequent as we saw with EV, and that is something we would like to tease out further as well. So I think overall, in the metastatic setting, this is certainly a very, very valid option, and I hope we can see it become available in US and other countries too, once we have more data.
Tian, question for you. What are the strengths and the weaknesses of the data that we've seen regarding DV and toripalimab? Where do you see the strengths and where do you see the weaknesses of this data set across the board?
Sure. Again, congratulations to the team for doing a really, I think, forward-thinking metastatic bladder cancer trial. And I think the strengths are really that we showed in a biomarker selected population, right? HER2 1, 2, 3 plus patient population, that there's a wonderful treatment effect of disitamab vedotin and toripalimab. This is an effective strategy. I think the strength is also that to the peripheral neuropathy perspective, it's only 17% peripheral neuropathy. And so that's a great toxicity benefit compared to EV and Pembro. And, I think there's a lot of strengths for a trial that I think had more your upper tract patient populations than we saw in other global studies. And so we're having more data about upper tract disease is also a strength here. So, from a large phase 3 study perspective, it's meeting all the metrics also on the efficacy front, progression-free survival, overall survival, duration of responses. So those are the strengths. On the potential weaknesses, I think we don't know how this patient population will reflect the rest of the world. So I thought that Andrea Necki's discussion certainly was a pertinent point. But we do have a registrational trial in the U.S. Of disitamab vedotin and Pembro, I believe, that will help us confirm these data. There's also, from a perspective, if you have a strength of positive upper tract disease, the question will be, how will it pan out for our patient populations where we don't have as many upper tract disease? And then to that point of upper tract and those complete responses, that was also pointed out as a weakness, less than 5% complete responses. This is a little bit, quite a lot less than EV pembrolizumab complete responses. So does that upper tract population factor into it? So a lot of these upper tract disease may not have full complete responses in the metastatic setting. And so potentially that might be a weakness of not driving to complete responses and consolidative treatments. So that's my overall thoughts. But overall, very positive study, and I'm really glad to see HER2 become a biomarker that we can use for this population.
Petros, quick question for you. The first is that maintenance of avelumab was not used, but at the same time, the control arm performed really well in this trial. And on top of that, a lot of subsequent ADC was used, which was not the case in EV302. It was very low use of global ADC. And that's because disitamab vedotin is widely used in China. What's your take on, is there any criticism of the trial design that you can see that people might, what's your take on that issue?
Tom, again, congratulations again to Professor John Gu and Xinan Sheng. Tom, you raised a great point. So I think overall, the points you raised are probably relative strengths of the trial in terms of the control group. If we go back in time in the EV302 that you did a great job presenting 2 years ago, the control arm was chemotherapy alone. And of course, available maintenance was used in about a third of the patients in the EV302 trial, which I think is probably reflecting real world practices. So that was acceptable, of course. But here, this was also kind of a part of the control group. I think it's interesting to see how many patients, got development maintenance in that cohort. I think it's at least relevant to know that detail. I think, as you mentioned, Tom, in terms of subsequent therapies, you see about 40% of patients got DV and/or checkpoint inhibition afterwards, which I think strengthens the data. Of course, we want to see as many patients as possible having access to subsequent therapies. Also, we know that there is significant attrition from first line to second line because many patients may have progression and not be able to have subsequent therapies. So I think overall, these aspects, Tom, strengthen the data. I would like also to see longer follow-up to see how patients did longer over time, because the follow-up can give us some information about the durability and how many patients could potentially, have long-term disease control longer term. And I think we have seen that tail of the curve with longer follow-up with EV302 and EV103. The last quick comment I have, based on what Professor Sheng said, about 5% complete response rate. I think this could be impacted by the makeup of the patient population, how many had lymph node only disease, how many had.
Great, Petros. Thank you. So, Shilpa and Tian, I'd like you to take this question on, if I may, and then I'm going to come to Jun after that. Some people hoped that there would be enrichment with the HER2 biomarker and that the response rates would go up to the HER3 population and there would be higher CRs and higher responses in that group. What's your overall take on the HER2 biomarker? Do we know enough about it? Because in the US, you use TDXD in HER3 plus patients as a single agent. So you have some experience of the HER2 biomarker. What's your take on this issue?
Yeah, that's a great point, Tom. And I think the problem we have in bladder cancer is that even if HER2 is overexpressed, we don't always know if it's driving the disease. And that's why all prior HER2 trials were negative. And the fact that in the TDXD Destiny pan-tumor trial, we saw some activity, but the number of patients was very small. And we did not see much difference between the HER2 2+ and HER2 3+, although approval is based only for HER2 3+. So that brings me, that makes me wonder if there's some other effects we are seeing from the DV that are resulting in the responses, which are not completely driven by HER2 per se. So I think we know that ADCs do other things just besides targeting. Just like, in EV302, we saw that Nectin-4 didn't really make a difference, whether it was high or low, the EV worked. So I think that's a similar story with this. And I wonder if we would really need to select for HER2. And that's a provocative question. I would love to hear everyone's thoughts.
Tian, what's your thought of the faraway Tian?
So on that front, so HER2, I was glad to see that the HER2 zero population was only about 16% in the consort diagram. So that didn't make it onto this trial. We do have a lot of experience with using HER2 IHC, both from gastric cancer as well as from breast cancer. And I think the HER2 definition that we've used for trastuzumab deruxtecan at least has been the gastric cancer definitions of HER2 positivity. And I think, from a practical aspect, HER2 IHC is easy to do and easier to roll out in our pathology labs. So I hope that more and more patients with bladder cancer will have HER2 testing and it'll be readily available to folks across the world.
Jun, I'd like to ask you a question. I could see during the presentation that while people started clapping, that you got a little bit emotional. How did you feel during the presentation, and how do you feel now with retrospect about what's happened?
Yeah, actually, after the presentation, I think that most people want to know in the future how to choose the first-line treatment for MUC. Because the data almost seems very same as the OS. You know, in the EV302 study, the overall survival is 31 months. Now, just equally with this EVT trial, the DVT trial, almost the same. So, which one should choose to be the first line treatment for some patients or other patients? I think that even the overall survival is the same, but we need to thinking about other things like the you just asked Zhang Tian that question is if the HER2 expression 3+, should we choose DVT first, or if the is 1+, we should choose EVP, or we didn't need use the DVT. Actually, in our study, we didn't have enough time to show the other things about like 1+, 2+, and 3+, the response rate about that. Actually, when we used the EVT for greater than 1+ patients, half of them are 2+, yeah, and the other half, a quarter of them is 1+, and the other quarter is 3+. At that time, actually, the overall survival a little bit difference, like in the 3+ group, the overall response rate could be 70. I forgot 73, 82%, and but when we put them together, it's 76%. Actually, the 2+ is about that, 72. Yeah. So actually, there are very small difference between the 1+, 2+, and the 3+.
My take on
the PFS also have no significant difference between the
my take on this, Jun, is the following, and I'm going to come to the panel in a second around this. But my take on this issue is the biomarker, the HER2 biomarker, probably needs some more work. And I think we need to look at EV Pembro in more detail with that HER2 biomarker to see if the efficacy in the HER2 3+ group and the expression in the HER2 3+ group for 302 for EV Pembro is active. Because there is concern, of course, that we have biomarkers here, but we're not using them properly. And I think we do need to do those experiments. So let's look at Nectin-4 expression and the relationship with HER expression. We've done some work on this, and it looks to me some of the initial work suggests that they're co-expressed. And let's look at those very highly expressed Nectin-4, maybe amplified Nectin-4, to see if the outcome of EV is better, and the HER2 3+ or amplified to see if that's better. Otherwise, I suspect most people will choose either EV toripalimab, EV pembro or DV toripalimab in the future. Shilpa, how would you make a clinical decision between those two if you had access to both?
Yeah, I think it will be great to have multiple options, just like in kidney cancer. You know, we always have this discussion with our patients, should we use IO-IO or IO-TKI, which again, we have 3 options available. So I think it's just going to be one of those things, Tom, that we learn to use DVT in our patient population, and I'll gain experience with it and see how patients do, and then make a decision of which patient may benefit from either. I think it's just us learning more about DVT. And I totally agree with you about the HER2 work from EV302 would be very important. And if we establish that EVP worked as well in HER2 positive expressing patients, I think that will really help us understand that it's not HER2 per se, it's just these novel ADCs are doing really great job there.
My summary of this is the following. The enfortumab vedotin and pembrolizumab data looks very strong and remains strong. The longer follow-up is reassuring. The toxicity profile is manageable for enfortumab vedotin and pembrolizumab, but it requires attention. I think the CR rate is an advantage. I see DV toripalimab, as Jun said, from the back of the room, the data looks very similar. I think there are some subtle differences in the toxicity profile because of the difference of the expression of the Nectin-4 and the HER2, and therefore there may be less skin rash, for example. But overall, I think there are more similarities than differences between these. Clearly, the DV requires the biomarker. The EV does not require the biomarker. So there's a potential advantage there. But overall, I would say these regimes are largely interchangeable, providing the patients are HER2 positive for DV toripalimab. And therefore, it's going to be more about clinical experience, about duration of therapy, about optimizing toxicity management, rather than arguing about which regime is better, because I don't think we'll ever do a trial comparing the two. Xinan, I want you to go to you next, and then I want you to ask Petros about this particular issue. You showed
Can I ask a question, Tom?
Yes, of course.
From Dr. Go and you.
Yeah.
So even though both these agents have vedotin, how do we think that the neuropathy rate is so much lesser than DV? But I also was in China last week and I noticed that the EV pembro expansion trial in China also had lower risk of neuropathy. So is it something about the Chinese patients that they don't have as much neuropathy, or how do we explain that neuropathy was really very good numbers in your study?
Yeah, for the just like Tom mentioned about that, the side effect seems that so different. Like in the EVP group, we found that the skin rash is very severe. Totally, because I have used the EVP and DVT in clinical, and I have this kind of experience a lot. Totally, I think that DVT seems have a lower toxicity than EVP, and because we can found that the EVP group, like EVP using patients always have those discontinuation or those
Discontinuation.
Discontinuation. It's a very common thing, but the DVT always could use the continuously until maybe the patient have very severe sensitive facial neurotoxicity, sensitive or numbing of the leg or foot, and people told me that he felt very bad, so we have to stop the dose, but always people could tolerate 4 to 6 cycles. It's very common, but the EV patients always discontinue or discount the dose after 2 cycles or even 3 cycles.
Because of neuropathy?
Or
rash. Rash. Okay.
So I think cross-trial comparisons for adverse events can be really challenging. And my experience of DV and pembrolizumab, which we've used quite a lot of, and EV Pembro, which we've also used, is both drugs have got side effects. And if you don't manage them well, the patients get into trouble. And there's a real important clinical learning curve associated with giving these regimes. I think they're both active. In the EV302 trial, the median number of cycles was 12. Petros, a question for you. How many is the right number of cycles of these drugs?
Tom, you're asking a very hard question. You know, we're having the same discussion with enfortumab vedotin and pembrolizumab in real practice, and I don't think we know the right answer to your question. We really try to tailor the duration of the individual patient based on toxicity and tolerability. And in clinical practice, we try to follow the EV302 trial design, where we continue EV until progression or unacceptable toxicity. But the reality is that many patients require dose adjustments, probably the vast majority, if not all patients. And at some point, patients may stop because of toxicity or preference. I think there's some data, Tom, from Memorial Sloan Kettering, Jonathan Rosenberg, and the team, that I think this is from EV monotherapy trials, if I remember, that if a patient has received at least 9 cycles, I think, of therapy or 9 months of therapy, and then they stop treatment, they have a high chance to maintain a treatment-free progression, survival without progression, which means that maybe some patients may maintain some durable benefit of treatment. We need to see this data, and I would love to see this data from this trial to do some analysis to look at the DV toripalimab dose exposure and see whether that may correlate or not with survival, because I don't think we know the right answer to Tom's question about the optimal treatment duration. And the last quick comment, Tom, we're trying to do some de-escalation trials, even in the US, with EV pembrolizumab to see whether we can have similar outcomes with a finite duration of the cytotoxic agent. It's hard to design those trials, and even with cooperative groups is some challenge. So I think it would be nice to have some real-world data and also those dose exposure to outcome analysis.
Let me move to Xinan, if I may. Xinan, you presented some neoadjuvant data. We saw some fabulous neoadjuvant data for EV Pembro at the meeting, with path-CR rates of 57% and hazard ratios of 0.4 and 0.5. You've shown path-CR rates in a similar level with DV toripalimab, but in a single-arm trial. What is the future of perioperative DV? And can we sequence DV toripalimab and EV Pembro?
For the now we have no trial to phase 3 trial to compare the DVT with the for example chemo combined PD-L1 antibody. Maybe Next year, we have conducted as a neoadjuvant phase 3 trial, maybe. But now we...
But you have not started that yet. And that sounds like a good idea. Tian, what do you make of sequencing ADCs, of sequencing EV and DV? It's got the same payload. My experience is there's probably cross-resistance between those two. Do you think that's the case?
Yeah, so that comes back to the question of the Venn diagram, Tom, of how many patients with HER2 1, 2, 3 expression also have good HER2, good Nectin-4 expression, and could potentially have treatment effect with both, right? So in the metastatic setting, that's a question that I don't think any of us would know right now. I think time would tell if we've had patients on DVT, then get an EV pembro maybe in your patient populations, or as they roll out in the US, maybe we have EV pembro patient populations that progress and then get exposed to DV with pembrolizumab. So I don't know how much that resistance will be mutual resistance. To your other question earlier about neoadjuvant, I think neoadjuvant is a sensitive time, right? And we think a lot about that curative intent. I was pleased to see that your DV study and the neoadjuvant setting was only 2 cycles. So could you potentially give 2 cycles of DVT and 2 cycles of EV pembrolizumab, get them the full effect of 3 months of treatment, and then get to surgery? So I think time will tell, but maybe we could be more creative about our dosing strategies and push patients into deeper response.
Concerns about using vedotin after vedotin?
It's a question. I don't know that we know, right? And so could we capture the most response? Yeah.
Jun, you've used a lot of sequencing ADCs. I'm aware of that. In your you've had access to DV and EV for some time. What is your experience of sequencing DV toripalimab, and what is your standard of care at progression?
Actually, in my personal experience, some very few patients failed with DVT and chemo. There's no standard treatment for him at that time. Sometimes people ask me if I can try EV monotherapy. Yeah, because at that time, this is the only choice option for him. So, in China, this kind of patient maybe have enough money to buy EV. So they buy EV and try it. And we found that maybe still half of the patients still have a response. Yeah, the tumor shrink, also very quickly. But most of the patients who failed with MMAE payload ADCs, we have other clinical trials, other ADCs, like different payload. We have another Chinese ADC, which is a target Nectin-4 also, but the payload is different as a top 1 or top 2, like that inhibitor. And we do found the patients who failed with EV could respond to this new ADC. Even they have the same target, but even the payload was different, the patients still have response. Yeah, so I think there's a very complete things that we need to think about the payload. We also need to think about the target. Because
Jun, I feel the cross resistance is probably more payload than target. But what you're saying today is you've seen responses by sequencing EV and DV. That's going to be very interesting for the future. We've got a couple of minutes to finish now. And what I'd like to do now is I'd like to go to each of the panelists and give a quick summary. And I'm going to start with you, Shilpa, if I may. And then just what do you make of what's happened in the frontline metastatic space with this new trial over the last day, and how has it changed your impression of the disease?
I think it's really exciting to see another very, very effective regimen that has beat platinum in the frontline setting, and so significantly. So I think the landscape is changing really, really fast, and the DV-TORI data will become very relevant for us in the US also, and Europe, and wherever EV Pembro is used, because once EV Pembro moves to the localized perioperative setting, we need very effective regimens in the frontline setting. And I would assume that those patients, if they recur, would not be immediately after surgery. So if and when they recur, I think this would be a great regimen. And I think, Tom, there's a lot of hope for the frontline regimen. That's all I can say with such studies.
And Tian, what about you?
I think, HER2 is becoming more relevant, right, for our bladder cancer populations. There is, I think, a push. We should finish the DV pembrolizumab trial globally for that next sort of wave of data about DV and pembro. It's a really exciting time, certainly, for metastatic urothelial cancer. And as we have more effective strategies, bringing them more into the curative setting, the more definitive setting, I think is a really nice opportunity for our patients with muscle-invasive bladder cancer as well.
Xinan, what are your thoughts?
This trial will change our Chinese doctor, and in China guideline had changed because this trial. So many patients can treat by the DVT, and I think maybe next we focus the new treatment for the patients who failed the DVT. Yeah.
Petros, your thoughts?
Yeah, thanks, Tom. Overall, I would say it's really transforming what we have seen the last, few years in this disease space. And even if we think about, again, theoretical, limitations that we alluded to before, Tom, how many patients got available maintenance, how many patients had access to subsequent therapies, these potential limitations can affect multiple trials. And in the reality, even if, the degree and magnitude of benefit would have been less impressive, I think would have still been statistically significant, clinically meaningful. So with those things in mind, the question I have, Tom, is, obviously we have the DV pembrolizumab trial ongoing, in US and other parts of the world, but could we potentially have access now, right, to this option? You talked about the potential difference in toxicity, could be a capture issue or, maybe less toxicity issue, but I would like to have that option for our patients, ideally. Obviously, regulatory agencies,
you'd like this approved. Shilpa, Tian, do you agree you'd like to have this approved in the US, or would you want to wait for the pembrolizumab DV randomized phase 3 global trial? What's your take on that?
It would be easiest to do an expansion study in the US population, just like, for EV Pembro, they did in the Chinese population. So we can generate data in this demographics that we deal with. I don't really think we would like to wait for DV Pembro. That may take a long time, but yeah, we want to know what that shows. But I think a low-hanging fruit would be to do a quick expansion trial if that were a possibility.
You're not good. Tian, you go, sorry.
Expansion or finish the global trial. I think both will allow us to have access in a pretty soon way to DV and IO.
I think the DV, I just want to make a comment, DV Pembro is also mostly ex-US, I think. Very few patients in the US, so yeah, it'll be interesting.
So in my opinion, Actually, I think that we have another option is a good thing.
Yes.
Like in kidney cancer, at that time, we have sorafenib, sunitinib, pazopanib, all other things, a lot of things, yeah. And now we only have two options. I don't think it's enough. And it seems that, do we only have one option is a good thing? I don't think so. We have a lot of options, always good things for any patients.
I agree.
Yeah. The two options is good. Even 3 or 4 options maybe
Better.
better than that.
My take on this overall, to sum up, because we've come to the top of the hour now, is to firstly to congratulate you again for this extraordinary session. I'm going to ask you to finish, Jun, if I may. I'm just going to summarize what I think of what's happened from a global perspective, and then I'd like you to say what you think is going to happen in China next, and then we're going to finish. So from a global perspective, I think we have all agreed today that these are practice-changing data, that I think it has had a global impact. I think that DV toripalimab is clearly active and looks similar in many ways to EV pembro, with some subtle differences. I think we want to see this as a global option for patients. We agree that we would rather have 2 regimes rather than 1. And we certainly want biomarker-driven regimes. We'd like to see more detail around these biomarkers moving forward, so we get a better idea of where we are. We would like to teach and educate the community on how best to give these drugs. And of course, the last piece is we need to work out the optimal duration of therapy for our patients as these move into the perioperative space. I would encourage you in China to do that DV toripalimab perioperative trial. I'm sure it would be positive, and I'm sure it would help patients in China and the rest of the world. Jun, give me a summary of what's going on in China, what impact this is going to have, and then if you'd like to wrap this up, that would be great.
Yeah. Very good question. Actually, when the CFDA approved the RC48 in 4 years ago. At first, we used the RC48 we called monotherapy, and now in the first line, people used it as the first line treatment using DVT together, and really, if the patient could not include the clinical trial, like the urologist always used DVT as even in neoadjuvant treatment, not only in UC. So it's very popular and used a lot in UC patients. Almost every patient used DV now. So that's also make us something like that. We need to find some first line. If we have another first line clinical trials, it's so difficult to find the patients who have not used the DV. So
30 years.
yes. Yeah. So even the urologists have do some IIT trials, use the DV as something like in the MIBC, NMBC, in the blinding, how to say, 灌注 infusion, and they try a lot of things using a TV. And I think that, so in China, maybe I think that not only in China, globally, does DVT or EVP is the final things for first line? I don't think so. Maybe in the future, 2 ADCs or some other like B-specific antibodies will be come into the first line to try. And now even we have almost the same overall survival and almost the same PFS in these two trials, but in the future they will you will forget it. Maybe the new first line will change our world.
Change again.
Yeah.
Jun, do you want to say a last word, and then we can draw a line?
Yeah, I think that you do a very good job, Tom. Thank you.
That's very kind.
You host the panel discussion very good.
Not as good a job as you did yesterday presenting the data. That's certainly true.
Thank you.
Congratulations.
Okay, thank you all of you. Give us a very good talk this afternoon, and I think that in the future we do need to collaborate a lot globally.
Yes, we do.
Yeah.
Absolutely.
And so I think that especially for China, we also need we need people like Tom to help us or to give us some guidance or suggestions for our clinical trials, or even some pharmaceutical companies have new product. We need to ask you to give your ideas how to do clinical trials using this new product to do meaningful clinical trials. I think that the globally collaboration could made new regimen and new drugs to the real world.
Yes.
To treat more patients and cure maybe someday.
That sounds amazing, and that sounds a great place to finish, Jun. Congratulations.
Thank you. Thank you again.
Tom.
Thank you, Tom.
Thank you.
Okay.
Great discussion.
Thank you.
Great discussion. Thank you for